Well, welcome to our webinar, Weight Loss Drugs, Are Diet and Exercise Now Irrelevant? I'm Mike Stack. I'm the CEO of Applied Fitness Solutions here in Ann Arbor, Michigan. And this is a conversation that I'm very excited to have with all of you because I think this is certainly the hot topic nowadays. And no doubt there's a lot of interest around these drugs and what does this mean for diet and exercise. I know some of you are listening to this who are considering these drugs, possibly, maybe even some of you who are listening are on these drugs at this point. So because of that, I want to make sure that we give a good understanding of what's going on with these drugs and how they work. So it looks like Kemper has joined as me on the webinar, which is very interesting. So Kemper, I'm going to ask you to log off, please, so the audience can see my smiling face instead of your headshot. There, he heard me. So this is a topic that is a hot topic. And again, we're going to get into a lot of this, but the place where I want to start are untopics. So things we're not going to talk about in this webinar other than what you see here on this slide. So first, we're not going to talk about how weight loss drugs are the easy way out. That's not a conversation we're going to have today because, as we're going to talk about, these drugs are far from the easy way out. We're also not going to talk about how maintaining a healthy weight is all about discipline and willpower, which I think for many, many years, that's been the narrative that has been preached by the evidence-based diet and exercise community, and it's definitely more complicated than that. We're also not going to talk about the terrible life-threatening side effects of weight loss drugs. Certainly, there are some side effects from these weight loss drugs, and we are going to talk about those, but we're definitely not going to talk about how these drugs are going to end your life eminently or something like that. We're also not going to talk about these drugs don't work, because as we're going to see as we go through some of the evidence, these drugs do work very well for the appropriate person. And we're also going to talk about the fact that diet and exercise are more effective than these drugs because they're actually not. We'll look at the data comparing these drugs to other interventions that are out there, and we'll see very quickly that these drugs are infinitely more effective than diet and exercise alone. And we're also not going to talk about the fact that healthy eating and exercise are irrelevant. In fact, we're going to try to reframe how we think about eating healthy and exercise. Now, here's some important disclaimers up front. I'm an exercise physiologist by trade and training. I am not a physician. If you are considering taking these medications or you're on these medications and you have questions, it's best to consult with a qualified medical provider, particularly with somebody who has a specialty in obesity medicine. All of you are going to get this PowerPoint sent your way after the presentation. You'll be able to click on that link that's right there to find an obesity medicine provider in your area. Those are really the best medical professionals to help you understand if these medications are appropriate for you and then manage their use. And then lastly, I think it's important to note that the evidence base is still emerging on weight loss medications. These medications aren't as new as what you might think they are based upon their popularity in the media nowadays, but they are still relatively new at scale for how they're being used. And so we have to understand that science is always emerging and evidence is always emerging. And what I'm going to present today, for the most part, is the best evidence available to date, although there's so much ongoing research on these medications that there's a good chance that something may have been published today that I missed because there's so much great science going on around these medications. So again, important disclaimers right off the bat here. So really what we're going to do is we're going to start by level setting, just kind of get a basic understanding of what we're talking about here and kind of why we're talking about it. We're going to develop an understanding of energy regulation because that's really the foundation of the conversation on which these weight loss drugs are based. We're going to talk a little bit how weight loss drugs work. We're not going to get deep into the pharmacology, but at least give you a basic idea. We're going to talk about the implications for diet and exercise. And then most importantly, I hope you leave here with practical recommendations. Now, I am going to try to leave some time for questions at the end of the webinar. This is Zoom webinar, so you can see me and hear me, but I can't hear you or see you. So we'll use the Q&A feature for all questions. I'll ask you to hold those till the end of the webinar, or if you're afraid you're going to forget, you can just pop it in the Q&A feature and I'll make some time at the end of the webinar to answer those questions. I'll also say that this is being recorded, so we'll send this out after the fact, so you don't have to take copious notes throughout the course of the presentation. And of course, then you could also share it with your friends and colleagues that may find this interesting. So to level set first, we have to understand how classifying overweight and obesity works from a medical perspective. Because as we're going to talk about in a second, these medications are only appropriate for people who are clinically classified as overweight or obese. Now, we do this based upon a BMI scale primarily. BMI stands for body mass index. I'm sure some of you that are watching this are familiar with that. It's essentially a weight to height ratio. It's your weight in kilograms divided by your height in meters squared. And this is a number that you've probably been talked about when you've gone to your doctor. And you see here on this chart, anyone who's under 18.5 BMI is considered underweight. Normal BMI is 18.5 to 24.9. And then we get into the overweight and obese category. So 25 to 29.9 being overweight, and above 30 being obese. And then beyond that, we just grade obesity at different classes. So class 1, class 2, class 3. Now, it's not just body mass index that we really want to look at clinically when we're trying to determine someone's weight status and the pathology associated with them being overweight. Waist circumference also plays a role. So we not only want to look at BMI, that's part of it, and in fact, that's the primary criteria as an indication for use of these medications, but men who have waist circumferences above 40 and women who have waist circumferences above 35 inches, they are at increased risk of disease because of where they store their fat. So part of this is understanding how we classify purely on a BMI level overweight and obesity, but the next component is understanding where you store your fat matters. And the reason that we look so specifically at waist circumference is waist circumference indicates visceral fat. So if you see here on the slide, you see this image of this individual who has subcutaneous fat, which is directly underneath the surface of the skin. This is the fat that you can see, you can feel. If you've ever had a skin fold measurement taken, this is the fat that's measured by a skin fold caliper. But there's a lot of other fat that's in the body. There's fat that's inside of our muscles. There's fat that's in our cell membranes. But there's also fat that sits below the muscle tissue in the abdomen, above and kind of mixed in with our internal organs. And that is referred to as visceral fat. So if you look here on the right of the slide, you'll see the subcutaneous fat is the yellow fat that sits directly beneath the surface of the skin and sits above and outside of our organs. Whereas the visceral fat on the left sits mixed in with our organs. And a lot of research suggests this is very pathological fat. This is fat that can produce inflammatory cytokines or basically inflammatory markers in the body. And we know that inflammation is the root of a lot of disease. So it's not only if you have a high BMI that should likely be considered, but also where your fat is stored should also be considered. So again, important conversation there just around understanding what the BMI number is, but also where it's stored definitely matters. Now, we also got to talk about what drugs we're actually referring to here, because I'm sure all of you are seeing so many things. You're seeing the brand name, you're seeing the generic name. So what are we talking about here? Well, really, we're talking about a class of drugs called GLP-1 agonists, which that stands for glucagon-like peptide-1 agonists. And you've probably heard commercials for some of these drugs under their brand name. Trulicity, Victoza, these are drugs that have been around for years and years and years and years. Those are kind of the first generation of these drugs that were primarily used for treatment of diabetes. And in fact, semaglutide, which is where we're going to have a lot of our conversation around today, was around in its original form of Ozempic, which was approved for diabetes treatment in 2017. And then the researchers started to notice this very interesting and desirable side effect that people were losing weight on these drugs. So then all they simply did was increase the dose of Ozempic or semaglutide to a higher dose form called Wegovy, and that was approved for weight management. That's a typo on the slide. It was approved more recently for weight management. But Ozempic and Wegovy are the same drug. One is approved for diabetes. A higher dose Wegovy is approved for weight management. And then there's this newer class of drugs that, again, I don't want to get too deep into the science here, but it essentially, instead of working on just the GLP-1 mechanism in the liver, it also works on this mechanism called GIP. And this is tirzepatide. So the brand names here are Mounjaro, Zepbound. I'm sure you've seen commercials for those. Most of our conversation today is going to focus around Wegovy. But a lot of the things we talk about with regard to Wegovy and semaglutide do apply to the GLP-1, GIP drugs like Mounjaro and Zepbound. So those are the drugs that we're talking about. And now we have to determine who these drugs are for. And this is a really important conversation because what I've seen in the mass media and on social media, I don't think exactly encapsulates who these drugs are for. So let's understand the clinical indications for who should even be considering these drugs. First and foremost, they have not been able to lose weight through lifestyle modification, diet, exercise, all the things that we do to modify our lifestyle to lose weight. And there's an inherent clinical need to lose weight because someone is overweight or obese. So the clinical criteria is, first, have not been able to lose weight through lifestyle modification. Second, you have a BMI of 30 or greater, and the BMI calculator here you can link to when you get the PowerPoint sent from us to you, so you can actually calculate your BMI. So a BMI of greater than 30 and not been able to lose weight through lifestyle modification, or a BMI of greater than 27 with one or more obesity-related condition or comorbidity, diabetes, heart disease, so on and so forth. So these drugs are for people who need to lose weight, who have not been able to do it through lifestyle modification. These drugs are not for getting the last 5 pounds off or getting your beach bod. They're absolutely not for that purpose, as we'll see. They do come with side effects and some other things to consider, but these drugs are definitely not to make you, quote unquote, look better or get your spring break bod or whatever words you want to put around it. I think, you've heard the jokes of celebrities being on these who don't need to be on these. I think somebody hosting the Oscars made a joke that looked like a lot of people in the room were on Wegovy. Again, I think we need to level set right off the bat and say these medications clinically are for people who need to lose weight based upon these criteria, who cannot through lifestyle modification. And this is a very true reality for many people. I've worked in this field for 23, 24 plus years now, and I've seen a number of people over the years that have tried through discipline, rigor, and hard work to lose weight through lifestyle modification, and they cannot do it. And for years, I think myself and other people in the evidence-based science community have said something else is going on here, and we just kind of haven't figured it out yet. And I think these drugs are really starting to help us understand the neurobiological basis for weight gain and becoming overweight and becoming obese. So let's get really clear on who these drugs are for. So with all of that as kind of preamble, I think we have to ask a foundation question. And it's a question of, is being overweight or obese bad for health? Now, Buzz Lightyear would say, yeah, that's a dumb question. There are dumb questions everywhere. But let's unpack this a little bit. Is being overweight or obese bad for health? Some of you may have heard of the health at every size movement and the body positivity movement that's out there. And regardless of if you think that's valid or not, it's not the point of this discussion. It really asks this fundamental question: is being overweight or obese bad for health? Now, you might say to me, in fact, some of my colleagues on this watching this webinar might say to me, Mike, look at all the diseases that are associated with being overweight or obese. And you can go around this whole chart and we could talk about all of the diseases that are associated, which that's the operative word there, with being overweight or obese. So I grant you that. Like these are real. This has been shown time and time again in the literature that there are disease states associated with being overweight and being obese. But I think we have to realize that correlation doesn't necessarily equal causation. And what I mean by that is we have to ask the question, is being overweight or obese causing the other disease states? Is it foundational to the cause, or do the behaviors that result in being overweight or obese also result in other disease states? And that's an interesting question, especially when you start to get into the research. So here's some research that was published recently back in 2021 that looks at disease states relative to BMI status. So you can see certain things, diabetes as an example, that seems to have a very strong correlation with someone that has a higher body mass index who is overweight and obese. You see, it's almost linear. As someone's BMI increases, so does their prevalence of type 2 diabetes. But you see other interesting things. As an example, the person who has heart disease at the greatest prevalence is the person who is actually underweight, not the person who is obese. And then something like cancer, you see the risk is relatively even for people at different body shapes and sizes and types. So this is nuanced. I don't think it's necessarily that we could say that being overweight or obese causes all kinds of diseases. It seems like it's associative. And then go a step further. This is one of my favorite graphs to put up in any presentation. One of the reasons it's my favorite to put up there is because it shows low aerobic fitness, low VO2 max, is a bigger predictor of all-cause mortality than cigarette smoking, which that's pretty profound, but that's not the conversation here. The conversation is if you look at this graph, you see that body mass index is not incredibly more correlated with mortality than high cholesterol, high blood pressure, and certainly smoking and low VO2 max have higher rates of mortality. So we kind of have to ask ourselves the question, that's a chicken or the egg question on some level here. So I want to kind of bring this to a close with asking the question and then providing some context just for you to think about. And the last point I think is going to be the important point here. I feel, and I think that this is looked at by a lot of practitioners in the field as probably being true, asking this question is more of an academic debate at this point than it really is a pragmatic reality per se. Correlation definitely doesn't equal causation. We cannot say that being overweight or obese causes these disease states. There definitely is an association. And the higher the BMI, the stronger the correlation. So, the more you get away from 25, 30 BMI to upwards of 35, 40 BMI, you're certainly starting to see a stronger correlation with a poor state of health. And this is particularly true with greater waist circumferences. So somebody with a higher BMI and a lower waist circumference actually may be at less risk of disease than someone with a higher BMI and a lower waist circumference. So I think it's really important to understand that where we store our fat does matter. Seems like maintaining a BMI of lower than 30 confers health benefits. That seems to be the case, and I think that's a reasonably evidence-based statement to make. But here is the most important thing. Here's the take-home. Research suggests that you can be healthier at any size with proper lifestyle modification. Somebody who has a BMI of 35, who exercises regularly, who is physically active, who eats a healthy diet, limits their stress, sleeps well, that person can be infinitely healthier than someone with a BMI of 30 who doesn't do any of those things. So I think it's really important to understand that, weight loss or not, we can be healthy at every size, healthier at every size, if we have proper lifestyle modification. So I don't think I can dive into this topic of weight loss drugs without at least establishing that first, because I think that's such an important framework to set up for so many people. Because some people are meant to believe that, hey, if I'm overweight, I can never be healthy. And you can always be healthier at any weight, given your lifestyle. So this gets us into starting to talk about these drugs a little bit. And we have to talk about energy regulation to understand how these drugs work. What you see on the right side of the screen here is commonly referred to as the calorie balance equation. In the upper example, calories in equals calories out, we maintain our weight. In the middle example, calories out end up becoming or calories in end up becoming more than calories out. So we gain weight, calories coming out be more than calories coming in. So we lose weight. So basic, simple thermogenics here. We've all seen this. It's a foundational concept. It's simple on the surface, but it's complex and nuanced on both calories in and calories out. It's not just as simple as this little seesaw picture leads you to believe. Weight loss drugs act on the calories in piece of the equation. They work on the calories in. Something like caffeine might work on the calories outside of the equation, as an example. And regulation of energy, primarily happens through the brain. And earlier I used a phrase that I think is really important that I want to touch on again, and it's the neurobiological basis for weight gain and, for that matter, weight regulation. And our energy intake, and therefore our weight, is controlled by our hypothalamus. It's controlled in the lower kind of subconscious parts of the brain. And the hypothalamus is receiving signals from many different tissues in the body, primarily from fat tissue or adipose tissue, as you see here in the picture, the pancreas, the stomach, and certainly other areas, but those are the primary areas. And the signals from the fat tissue are in the form of a hormone called leptin. Leptin is our satiety hormone. So this hormone, when we have high levels of body fat, we produce more leptin, and that basically sends a signal to our hypothalamus to say, eat less. As we get lower and lower levels of body fat, as we lose body fat, we produce less leptin, so we're less satiated, so we're driven to eat more. Now, the pancreas is really where we're going to spend a lot of this conversation, as well as the stomach. The pancreas is what GLP-1 acts on. And basically what it does is it promotes the release of insulin from the pancreas. And as we're going to see on the next slide, this is a sign to the body that the body is fed and it doesn't need to eat. So this down-regulates our energy intake. Insulin is released when we eat food to store the food in the cells of our body. And when insulin levels are artificially raised through GLP-1 drugs, it's sending this signal to our brain that says, hey, you're fed, you don't need to eat. And then lastly, the stomach. When the stomach is full, when the stomach is distended, when we have foodstuffs in the stomach, our stomach pumps out a hormone called ghrelin normally, and that's the hunger hormone. So when your stomach is empty, you're pumping out large amounts of ghrelin. As you get full, your stomach pumps out less and less and less ghrelin. So we're going to see that this is a mechanism that these GLP-1 drugs work on. And there are genetic and epigenetic differences in all of these signals. So there are some people that are very sensitive to leptin, have good insulin production capabilities, and their body has a good balance of ghrelin to leptin. So they stop eating when they're actually physiologically full. They eat when they are physiologically hungry, and the body works properly. However, for a lot of people, particularly people who struggle with their weight, these systems are dysregulated to a certain degree. And we won't get into all the nuance of the dysregulation, but the fact of the matter is that somebody who has a BMI of 45 or 50 that is eating constantly, the people on the 600-pound life, you wonder, like, how are these people constantly eating food? It's because their energy regulation system is actually out of balance. Something is wrong on a physiological level for these individuals. Not a matter of willpower or discipline. They actually process their hunger signals differently. And that's what these drugs look to act on. So if we want to put this in scientific terms, what these drugs do is, first, they slow gastric emptying. So they increase fullness. Basically, they slow the rate that food leaves your GI tract. That decreases your ghrelin levels, which is your hunger hormone, so you're less hungry. It stimulates insulin release, and this reduces hunger because, again, that signal that insulin is in the bloodstream is a sign the body was just fed, so it starts to shut off those hunger signals. And then gone one step further, the kind of countervailing hormone to insulin is a hormone called glucagon that we haven't heard as much about. This suppresses the hormone glucagon. And again, that reduces hunger because times where there is higher insulin and lower glucagon, the brain thinks it's just fed. So that's how we think of this in scientific terms. I realize this isn't a science class, so we'll actually take this one step further and we'll explain this in a picture. People who have dysregulation to their energy thermostat in the brain, which is how I think we can think of the hypothalamus, they're constantly thinking about food, constantly. And maybe this is somebody who's listening to this webinar right now, but we know through research that individuals who have a hard time managing their weight, food is always on their mind because there's a subconscious biological drive to be constantly thinking about food. So in effect, what do these medications do? They clear up the noise. So you're not always thinking about food all the time on that basic biological level. So you can focus on other things. Now, regardless if you like my clip art and my custom animation here or not, I think the point should be well taken. Individuals who struggle with their weight are always thinking about the next meal, the next opportunity to get food. And that's not just as simple as the cognitive process of saying, hey, don't think about food. This signal is emanating from the deep centers of our brain that were evolutionarily developed to keep us alive. So it's not as simple as just not thinking about food. On almost a deep evolutionary level, these individuals view food or lack thereof, at least perceived lack thereof, as a threat to their very survival. So all these drugs do is they kind of reset the energy thermostat. It's almost like your thermostat in your house isn't working properly. It's not functioning and regulating the temperature in your house. So you go get a new thermostat, you plug it into the wall, and now it starts to regulate the temperature in the house better. It's almost like that's what these drugs do. They just free up mental bandwidth. And I have some friends who are researchers in the space. One of my very good friends, Renee Rogers, who some of you might know who are on the webinar. She's a PhD at University of Kansas Medical Center. She does a lot of research on this. She's actually done interviews with people who've been on these medications. And she literally says that the people tell her it's like a weight has been lifted. They're not thinking about food all the time anymore, and they have the mental and emotional bandwidth to start to think about other things. And again, I think this is upending how we thought about people who were overweight or obese for so long, that it's a lack of discipline, it's a lack of willpower. I would say, based upon these medications, it's a lack of a certain biological mechanism working properly. So do these work? Well, if we look here, and we compare all the different ways that you might try to go about losing weight, you see something like exercise. Maybe a good exercise program will help you lose 3% of your body weight. Nothing to shake a stick at, because 3% is definitely a way to improve your health. 3 to 5% reduction in body weight definitely improves your health. You combine diet and exercise together, you can lose 10% of your body weight. You go on a very low calorie diet, so like a liquid diet, maybe 12.5% of your body weight. But then you start to get into the GLP-1 drugs and the GIP drugs, and you start to see significant amounts of weight loss. In fact, as you see on the far right of this graph, gastric bypass, the surgery, which reduces the size of the stomach, that does show the most significant weight loss. Obviously, that's a very invasive procedure, but some of these drugs have been rivaling gastric bypass surgery in terms of their rates of weight loss. So they do work. And we have to understand that a lot of what's reported is kind of cohort level averages. So if we look at the individual responses, the weight loss range for Wegovy tends to be about 5 to 15%. For Mounjaro, it tends to be somewhere between 5 and 25%. So there is a range. I mean, it is the normal distribution. Some people lose an average amount. Some people lose a bunch. Some people don't lose so much. 15% of patients don't lose weight at all for some reason. So the trials have showed that up to 15%, just they're non-responders to this. So that is also a reality. We're seeing averages. We're not seeing the actual individual data points, which is what all you care about that are listening. If you're considering these medications, this isn't, you don't care about the average. You care about how it affects you. They're approved to treat diabetes, obesity, and most recently cardiovascular disease, but there is so much research underway to where they're showing promise with polycystic ovarian syndrome, sleep apnea, Alzheimer's disease, non-alcoholic fatty liver disease, addiction and mental illness. There's actually some thought that these drugs help work on some of the biological mechanisms of the brain that drive addiction. So these drugs really are fascinating, and they are very, very promising, and the literature is evolving. But again, going back to what we said earlier, they have to be for the appropriate person, and we have to realize that not everyone responds the same way to these drugs. And there certainly are side effects. And with any medication, there is a side effect. There's always a trade-off. And the most common side effects are GI side effects. And this makes sense because this causes food to stay in the GI tract longer. So people might get nausea, vomiting, diarrhea. Again, not an uncommon side effect for this medication, and for that matter, for other medications. Low blood sugar levels is also a side effect. As you basically produce more insulin, you can drive your blood sugar down more, so that's a side effect. These medications, when they work, really do curb appetite and energy intake. People see dramatic reductions in their energy intake. And when that happens, you are going to have lower energy levels. So if you're someone who is taking one of these medications and you're trying to engage in an exercise program, you may have to be aware of the volume and intensity of your exercise to ensure that you can adjust to lower energy levels, because your energy will go down when you eat less. Food is literally energy for the body. There's a significant loss of lean mass with these medications. Research suggests at this point that up to 40% of the weight lost is lean mass. And I really want to pause on this one for a second, because I think this has gotten a lot of unnecessary bad press because people don't really understand the context. First, at this point, we don't know how much of that weight loss that is lean tissue, so non-fat tissue, how much of it is actually muscle tissue. Lean tissue and muscle tissue are not the same thing. Muscle tissue is a part of lean tissue. So when you lose lean tissue, it could be water, it could be stored carbohydrate weight, could be any number of things, not all muscle mass. And there's research underway. My friend Dr. Rogers that I mentioned earlier, I believe, is conducting some of this research at KU Medical Center to look at how much of the weight lost is actually muscle mass loss. So for all those things you read online of it stripping muscle away and you're losing all your muscle tissue and you're losing all your strength, that is not founded in any research right now. That's just a bunch of hyperbole. And I think people that are almost fear-mongering to say, hey, you shouldn't take these medications. The other thing with lean tissue loss is it's totally normal when somebody loses body mass for a decent portion of that to be lean tissue and even muscle tissue. I mean, think about it. If you go from 300 pounds to 200 pounds of weight, there's 100 less pounds of your body that you have to carry around. And so you probably need less muscle tissue to carry around 100 less pounds. So losing lean mass and even muscle mass is totally normal when you are losing large amounts of body fat. And what I would submit to all of you, and we'll talk about this towards the end of the presentation, it's not how much muscle mass you have to a great degree, it's what that muscle mass can do. And so there's a correlation between quantity and quality of muscle, but it's not a direct correlation. Somebody who loses a bunch of weight, who's never strength trained before, starts to engage in strength training during a period of weight loss, they might end up with quantitatively less muscle tissue at the end of their weight loss, but qualitatively muscle tissue that is stronger and more powerful and more functional. So we really have to watch the indictment of these drugs from a lean mass perspective, because it's a little bit more nuanced than what the talking heads out there will want you to think. Lifelong use is required to maintain therapeutic benefit. This is very, very clear. These are medications that they are changing the biological factors associated with your energy regulation. If you get off the medication, all of those biological factors regress back to how they were previously. So no different than our thermostat analogy. If you install a new thermostat in the wall to regulate the temperature in your house, and then you decided to plop back on the old thermostat, you're going to see the same thing. So at this point, based upon everything we've been told, lifelong use is required to maintain a therapeutic benefit. And so that's a consideration. But I would also submit to you, there's people that have genetic hypertension and genetic high cholesterol, that they stay on a blood pressure medication or a statin their entire life. And we don't think of that as bad because it's treating a genetic condition. So I think on some level, this might not be that much different. And then lastly, these are costly. Current retail prices are, upwards of $1,000 per month, maybe a little bit more, maybe a little bit less in some cases. And if you're around the payer community, the insurance community, you know that there is great concern about these medications and if they should be covered. And there, at this point, there seems to be spotty and minimal coverage of these medications. So I fear that the financial factor may be a limiting factor for many people. We talk about in health equity how sometimes dental hygiene is a marker of socioeconomic status. I think for years, weight has also been a marker of socioeconomic status, and I fear that with these medications, it might even become more so. Now, there is work underway from a regulatory perspective to see if we can get these medications covered more, but there's a lot of complexity with that. So again, these drugs work, no doubt about it, for the vast majority of people, but there are trade-offs. So here's the question: are diet and exercise irrelevant? That's the question. Well, first, let's look at the package insert for Wegovy. Now, I'm not expecting you to read any of this. I'll actually read you the most important part under indications and use. It says Wegovy is a glucagon-like peptide 1 receptor agonist indicated in combination with a reduced calorie diet and increased physical activity to all the benefits that it provides. So indicated in combination with. So even on the package insert from the manufacturer of the medication, they are suggesting that this is not to be used in isolation. This is to be used in conjunction with. So that's something to think about. The other thing to think about is, what are the benefits of a healthy diet? All the stuff you see on the screen here, right? All these things are benefits of a healthy diet. And if you think about what these medications address, really, it's kind of those three things, right? They're approved for weight management, approved for blood sugar management or diabetes, and they're approved for cardiovascular health. All the other things, all of these are really, really important reasons to eat healthy. And if you want to leave these on the table, I guess you could not eat a healthy diet when you're on these medications, but improving your mental health, your bone and your teeth health, your digestive health, reducing cancer risk, go down the list, man, those seem like all great reasons to maintain a healthy diet. And, we can do the same thing with exercise. What does exercise do? Well, as you see here, it does a lot of the stuff that you see on this slide that's very similar to diet. But again, improves cardiovascular health, weight management, and reduces risk of chronic disease. Yep, that's exactly what these GLP-1 drugs do. But all these other things are very important things. Enhances aerobic fitness, boosts endurance, improves mental health, brain health, sleep better, opportunities for social interaction. Like the question becomes like, do you really want to leave all of that on the table just because a medication provides you, 10% of the benefits that diet and exercise can give you? And that's really how I think that as professionals in the industry, we need to be approaching this, as well as the general consumer, is that we could start to shift our paradigm. The old paradigm was a very myopic view of diet and exercise, and that's changing. The commercialization effort in the industrial complex that is the diet, exercise, and fitness industry convinced us that the way we exercise and the reason to exercise and the way we eat and the reason to eat healthy was about the way we look. That has been the narrative that has been pumped out by not just the diet community, but also the exercise community. And I've been a part of that at certain points in my career, and I believe I'm reformed now. I think some colleagues have been like that. And we realized that we really were peddling the wrong narrative. Science reminds us that the way we look and how we manage our weight is more of a side effect of a healthy diet and exercise than it is necessarily a direct effect. Science tells us that diet and exercise are about how we feel, how we function, and how we perform, not how we look. And it's so important that we start to disentangle the two. So these weight loss drugs, in my mind, are now starting to begin to reconnect many people with the foundational reasons to eat a healthy diet and to exercise. It's kind of starting to strip us of this narrative of you got to do this to look a certain way to, wow, you get to do this to feel better, to function better, and perform better, which at the end of the day, I think that's what most people are going for if we can kind of extricate ourselves from this diet culture that kind of praises thinness and a certain aesthetic ideal and say, all right, well, that's not reality and that's the magazines. And in many cases, that's not even healthy. This is about how we feel, how we function, and how we perform. So in my mind, the old paradigm is, and I've heard this paradigm before. In fact, I feel like on some level, at certain points early in my career, I perpetuated this paradigm. I must eat a healthy diet and exercise to look a certain way according to societal standards. I think that's not only something that I may have perpetuated earlier in my career, but I also think that's something I felt that I needed to do for myself earlier in my career. That's gone now, or at least it can be gone with these medications. And even if you're not taking these medications, I would urge you to strike this old paradigm from your thinking and adopt a new paradigm, which is I can eat a healthy diet and exercise to be healthy, live the life I want to live, and do all the things I want to do. We're going to talk about this many, many times here throughout the end of this presentation. That's a lot of what exercise and diet are all about. It's being able to have the energy, the vigor, the vitality to do the things that you want to do in life. And I think these medications are freeing up mental bandwidth for people to be able to do that. So that leads us to this concept of physical fitness. And this is the definition from the American College of Sport Medicine that I won't read this word by word, but I do want to point out, I think, the most important words. With ample energy to enjoy leisure time pursuits. With ample energy to enjoy leisure time pursuits. With ample energy to do the stuff that you want to do during your life. I watch my parents, who are both 70 years old, run around after my crazy 10 and 8-year-old nephews, who are absolutely amazing, but they're two 10-year-old boys, or a 10-year and 8-year-old boy, and they are just tornadoes of energy all of the time. If they didn't have a level of fitness, they wouldn't be able to have the energy to enjoy that leisure time pursuit. So this is literally, which granted, I don't know if you asked my parents if they thought it's leisure time all the time, but nevertheless, I think on balance, they probably do enjoy it more often than they don't enjoy it. So I think that's the point here, is that we can be fit, we can eat a healthy diet to do the stuff that we want to do for as long as we want to do it. And how liberating is that? And so when we think about this, fitness is broken down into health and skill-related physical fitness. These are the definitions. I'm not going to get into these definitions, but needless to say, if you have health-related physical fitness and you have skill-related physical fitness, you can do almost anything that you want to do in life. And that is, not only is it very empowering and very fulfilling, but it's also a way to maintain autonomy throughout your days. I want nothing more than to basically be going full speed until my 80s, 90s, or 100s and just fall over dead at that point. I want my health span and my lifespan to be exactly the same thing. And you do that through a healthy diet and through exercise. Now, just to kind of further reinforce this, here's some additional research. Here's a look at grip strength and mortality. So right here, you see a massive, massive cohort study that was published back in 2015 that showed that grip strength was a bigger predictor of all-cause mortality and cardiovascular mortality than high blood pressure, and MET minutes per week is just physical activity per week, basically. So something like grip strength, so you don't see BMI here, you don't see body fat percentage on here, you see grip strength as the biggest predictor of mortality. Doesn't mean if you have a really strong handshake, you're going to live forever. Grip strength is just a great proxy for overall body strength. So again, this is advocacy for the need to be physically active. What's interesting, when you look at weight and mortality, some of the biggest predictors of mortality actually occur on the lower end of the BMI spectrum, not necessarily the higher end. It's not exactly a direct correlation between weight and mortality status at the upper end, but in a lot of cases, on the lower end of the BMI spectrum, less than 18.5 BMI, that is very predictive of mortality, largely because those people lack the functional strength. And man, this is probably one of my favorite graphs of all time. If you've heard me lecture before, I put this graph up there because I actually think this graph is the most important public health message that exists that we don't put out there. This is research from past and late ACSM president, Dr. Stephen Blair, published back in 1989. So this is not something we learned just yesterday. And it looks at mortality rate based upon level of aerobic fitness. And you could see two things on this graph. The first thing you could see is that when you go from low to high aerobic fitness, your mortality rate drops. That is nothing that is earth-shattering to anyone on here. However, what should absolutely shock you is the drop between the lowest level of aerobic fitness and the second lowest level of aerobic fitness in terms of mortality. It is a 50% or more reduction. So basically what this graph is saying, if I could put it really simply, is that when you go from really, really, really out of shape to just really, really out of shape, so I've removed one really there, you cut your mortality rate in half or more. That is a profound implication, and you do not see that relationship with body mass index, with body weight, with body fat. There's not that relationship. And we could take the word mortality and we could take it out, and we could put in the word morbidity or disease states, and you would see something very similar. Going from a really, really, really low level of fitness to just a slightly lower level of fitness greatly improves health, reduces mortality, and reduces morbidity. So really what this graph shows is that we can flatten the curve. I always remind people that I said this way before Anthony Fauci said this. He stole this from me, so he might owe me some money. But what that graph shows is that you don't have to go from being a couch potato to being a jacked potato to significantly improve your health. You just have to be a slightly more active potato. And beyond the fact that you should be impressed that you can find a flexing potato somewhere on the internet, don't ask how long that took me to find that. What should blow you away on this graph is the slope of the line right there. That's the most important public health message that I don't think we talk about. We don't talk about the fact that you just need to go from doing nothing or very little to something or a little bit more, and you can profoundly improve your health. And that doesn't have to happen, by taking a medication. That doesn't have to happen by even coming to a gym and exercising. That can happen by just taking a walk outside. Now, what these medications can do for people that they are indicated for is they can free up the mental and emotional bandwidth to be able to orient themselves towards exercise, because they're not always having to think about what they're eating next and where their next meal is coming from. Because again, that neurobiological wiring is a little miswired in these individuals. So again, I can't stress this enough, is that yes, these medications work very well, but clearly diet and exercise confer significant health benefits. And why would we want to miss out on those, particularly for the people who are taking these, who don't have the mental bandwidth to engage on this? So take-home message before we open it up to questions, and I'm sure there will be some questions here. First and foremost, as I said, there is a neurobiological basis for obesity and for overweight. Individuals who struggle losing weight through lifestyle modification, some of these individuals just simply are wired differently on a neurobiological level. And just like any genetic predisposition that drives disease, eventually the medical community comes up with a treatment for it. That's what we have here. We have a treatment for this. So it is real. The medications work. They work differently for everyone. For some people, as you saw in the research, they don't work, but the vast majority of people they work for, and they work very well for. There are downsides to taking this medication or any medication. No medication that we take is free of risk. And really, it's just weighing your risk in the situation to see if this is something that makes sense for you. And again, that's where the encouragement is to talk to a qualified professional if you're considering this. We definitely need more research, and we need to be looking at reputable sources, for our research. So, I would encourage everyone that when they're trying to find research on this, try to go to somebody who is as objective and evidence-based as they possibly can. But, anyone that's telling you that these medications don't work, they're not following the evidence. Anyone who's telling you that you don't need to eat healthy or exercise anymore because of these medications, they're missing the forest for the trees here, because there are so many benefits. Again, consult a physician if you're considering use, or if you are currently using, and maybe you're not getting the outcomes you're looking for, you're having undesirable side effects, it's really important to have conversations with a qualified medical provider about this. And again, we'll send the slide deck out so you can connect possibly with an obesity medicine physician in your area. And then lastly, and I think most importantly, a healthy diet and exercise are more relevant now than ever because of these medications, because we can reconnect with the real reason to engage in a healthy diet and exercise, and that's to live the life we want to live. That is really the take home here, is that these medications just free up that mental and emotional bandwidth to orient ourselves to other health behaviors that we can now approach because we have the mental space to be able to do so. So I wanted to provide some additional resources. Here are 3 links. Again, we'll send this out in the email afterwards so you can see this. Here's an article on how to maximize the benefits of weight loss medication. There's also 2 podcasts that I've linked to that talk about these weight management drugs. Although these podcasts are from my Wellness Paradox podcast, which is more for exercise professionals, certainly anyone listening to this webinar could benefit from probably hearing the perspective from evidence-based individuals in the weight management space that are talking about how professionals can think about approaching this. So this is my contact info. If you want to reach out to me, you could just shoot that little doohickey on the screen. I see I have some questions in the chat. So let's see. First question, if you're receiving hormone therapy for cancer and have excessive weight gain, can these drugs be effective? So that is something that I actually do not know the answer to, and I don't know how much that has been studied at this point. A lot of times during certain hormone treatments, you can have certain things that cause weight gain because it's causing water weight gain or inflammation in the body, and that actually won't be mitigated by these medications. So the question that's been brought up here is a question of contraindications or indications, how these medications interact with other medications. That is where I think an obesity medicine doctor or a pharmacist that understands the pharmacology of these really well, I think that individual can help guide that. And I would also suspect that it is probably hormone therapy specific. So this is where you would have to dive in with somebody who actually understood the pharmacology. So if you take these drugs and stop, will the weight come back? Yes, that is at this point, based upon all the research that has been done, if you are taking these drugs, they kind of reset this energy thermostat in your brain that allow you to eat less and lose weight. You stop taking the drugs, the energy thermostat gets dysregulated again, you start to eat more, and then you start to regain the weight. So we kind of presuppose that because these drugs are fixing a disrupted mechanism in the body, when you stop taking them, the weight comes back on. And the research has also shown that thus far as well, that as people start to go off these medications, there is a very pronounced weight gain. All right, I'm going through the other questions here. What considerations, if any, should we take into account with our exercise plan when on these medications? So I'll answer that question from the perspective of somebody who is currently exercising and then starts these medications. So what I would always recommend, and maybe I'm a little biased here, is that you should really be working with a qualified exercise professional that understands how these medications work and how these medications will affect you. But I think what is probably most appropriate to do when you first transition onto these medications is to be very, very aware of your exercise intensity as much as anything else. I think it's reasonable to maintain your frequency in your workout. There probably aren't any modalities that are contraindicated per se, but intensity is something to really watch simply because you'll have much lower energy levels when you're on these medications. And because of that, you may have to adjust your exercise intensity. I would be hesitant to adjust frequency because I think it's important to maintain the habit of exercise, but in terms of the intensity that you're exercising with, I would definitely recommend ratcheting it back a little bit and then scaling it up slowly. The other point that I think should be taken into consideration with exercise is your food intake around exercise. Maybe you eat lunch normally, maybe it's a certain size lunch, and then you work out right after work at 4 or 5 o'clock. Well, depending on how much you normally eat for lunch and how slow the gastric emptying is, you could start your workout with a fuller stomach than what you might like. So I think that's something to bear in mind and experiment with. You may have to push meals further away from your workout. You may also have to reduce normal meal sizes before a workout just so you don't have too full of a stomach and you're uncomfortable when you're exercising. So those would be my two considerations, is probably moderate intensity based upon the energy levels you have, and be very aware of your food intake in and around exercise, just to make sure you're not horrendously uncomfortable during your workouts. It's not like having food in your stomach during exercise is a bad thing. It's just that it might make it an uncomfortable experience. Let's see. I'm often asked by clients if they should consider using these medications. Are there any things fitness professionals can suggest their clients discuss? Are there things a fitness professional can suggest their clients discuss with a physician? I'm thinking back to when I worked with people in CBD and I helped them collect blood pressure data with their doctor. Thanks. So yeah, so I do think it is important for patients to be armed with the right information when they seek to have a conversation with their physician. So I think what would be really, really helpful is if they documented their attempts to lose weight throughout the course of their adult life, at least through the recent history, what that has looked like, and maybe what their weight trend has done for several years. I mean, essentially, the question that's being asked here, Ann, is like, hey, we used to collect blood pressure data. That's a biomarker. So what are some of the markers here? And I do think it is kind of, longitudinal weight history. And then I also think it is documenting some of the attempts that have been made in the past. I think that's what starts the conversation effectively. But I also think this is where an obesity medicine doctor is very helpful to be able to have a conversation with, because these are individuals that have a little bit more clinical training and some of the nuance associated with this. So as a result of that, I really do think that if you can get a referral to one of those individuals or just get to one of those individuals straight away, it's probably going to be a conversation that's a little bit more reasonable. Any other questions? Let me see. Let's see. Do we yet know if you have to stay on the same dose for a lifetime, or do we know if people can titrate down? Yeah, that is a really, really good question. And I don't think those clinical trials have been done on a large scale. But if we just extrapolate from other medications that are out there, we know that there is a very real dose response relationship to medications. So that means as dose goes up, response goes up. As dose goes down, response tends to go down. So I would venture to say if what we're seeing is people that get off these medications regain all of the weight that they've lost when they're on them, I would venture to say that people that titrate the dose down would also probably see a corresponding increase in their weight. Now, if they're still on the medications, they may see some weight loss maintained, but it stands to reason that just due to the dose response relationship that exists, I would expect for every incremental dose you reduce these medications by, you would see an incremental increase in weight. How's the research showing athletic performance decreases when an athlete is on these drugs? I have zero recollection of any research that has been done on an athletic population at large scale on these drugs. The only anecdotal evidence that I've seen is Nick Shaw, who is runs a company called Renaissance Periodization. He used these, and now let's be clear, he said this on a podcast, so he's very open about it. He used these for dieting down for a bodybuilding show. So we use these from an ergogenic perspective, which is not the reason to use these at all, but we do know people who are in that world who use all kinds of drugs to improve their performance, and that's the decision that they've made. So no moral judgments on it one way or another, but what I heard Nick say on that podcast was that his energy levels and his performance were substantially reduced. So, I mean, I think you can make the assumption that just like anything else, when you reduce your energy levels, it's going to reduce your performance. But I couldn't even tell you an athlete that I know or I've heard of who's on these medications. So yeah, I would venture to say that's still a really questionable area of research. And that truthfully, I mean, a lot of these questions that are being asked by all of you as the audience, these are really the questions that I think the pharmacology community are asking, the medical community are asking. We have some information, but we don't have all the information yet. So I think today was a great first step to all of you starting to learn about this. But keep your ears open, keep your eyes peeled, keep learning the evidence base, keep asking questions. I had one last question on here that we'll be able to get to. What do you think about keto gummies that the social media is raving about? To be honest, apparently I don't spend enough time on social media because I don't know of these keto gummies. But most things I find that social media is raving about does not have any strong basis in the evidence, just because that generally tends to be the nature of normal social media. What I can tell you is that if you try these keto gummies, they're probably not going to hurt you. They might help you. And if you're willing to spend the money, you could give it a go. But the keto concept has been shown time and time again in the literature to not confer any more advantages than just standard diet changes. So I would say there's nothing inherently special about ketogenic gummies or anything of that nature. Lots of great questions. I do want to be respectful of everyone's time because it is 1 o'clock. Thank you, everyone, for attending. I hope you found this knowledgeable. Be on the lookout for an email coming your way with a recording of this. And if you do have any questions, please feel free to reach out. Thank you.